happy to be here. I will go ahead and attempt to share my screen. Hopefully people are seeing it. So yes, okay, and I will just ask somebody to moderate the chat for me since I'm not able to see it on my screen and I'm technologically challenged. So I am a clinician educator, and I know this is a more research-oriented group, but what I thought I would do is give some clinical HIV updates, state of the art, pun intended. So really focusing on antiretroviral therapy and some of the recent things that have come out over the past several meetings. And I guess the perspective to take for all of you is sort of, this is, if I could title this talk, these are my favorite abstracts from the past 6 months. That's what I would call this, but you could kind of look at it as what is a clinician kind of keeping their eye on in terms of what is important and kind of at top of mind for HIV clinical care. I don't have any relevant financial disclosures. I do receive speaking fees from educational companies, and many of the slides that I'll be presenting today I've co-created with them. So here's an outline of the topics that I'm going to cover. I'll review mostly abstracts that have been presented at meetings and conferences over the past 6 months, focusing on HIV and viral hepatitis, long-acting injectable cabrylpivirine updates. I'll go over some efficacy data on patients that aren't typically included in clinical trials for antiretroviral therapy, like those with low CD4 cell counts or high viral loads, and then give brief updates on some investigational agents, or just one agent actually. And this is going to be really a whirlwind, covering a lot of different topics and areas. So we won't go into anything too in depth, but kind of give you sort of a broad brushstrokes overview of some of these hot topics. And for each of the topics or abstracts, I'll try and give some takeaways about how I'm thinking about potentially applying this to my clinical practice. So we'll start with some updates on HIV and viral hepatitis, really focusing on HIV and hepatitis B co-infection, with one mention for hepatitis delta. So the first study I wanted to highlight was presented this summer at IAS, the Alliance study. And I think the reason why I wanted to highlight this is because I think it came out and was presented and didn't get maybe as much press as I thought it might. And it was kind of a surprising result. So just wanted to kind of bring it to attention in case you hadn't heard too much about this. So this was a randomized controlled trial of patients with HIV and hepatitis B co-infection who were treatment naive, and they were randomized to either the bictegravir FTC TAF arm or dolutegravir FTC TDF. So of course the INSTIs being different between the two regimens, but also TAF versus TDF. And they had two co-primary endpoints, HIV virologic response, as well as hepatitis DNA virologic response or suppression. And the data that was presented at IAS was the 48-week data for the current analysis. And so I think, as not surprising to most of us, there really wasn't much difference in terms of HIV virologic suppression between the two regimens. So the BIC FTAF group is in blue and the dolutegravir FTDF group is in orange. But I think what was more impressive was the improved outcomes with respect to hepatitis B and liver tests that we saw with the TAF-containing regimen compared to the TDF. And this included hepatitis B virologic suppression at week 48, as well as normalization of liver function tests, both of which were statistically higher in the TAF-containing regimen. And then there was also improvement in terms of seroconversion, both in terms of e antigen and surface antigen, at least trending in that way in terms of surface antigen, and then statistically significant with respect to e antigen seroconversion. So I think the take home from this, it doesn't really change my clinical practice all that much, because I think in the vast majority of patients, I'm using a TAF-containing regimen when I am using tenofovir as opposed to TDF. But it's just to bring awareness that if I do have a patient with HIV hepatitis B co-infection, I think this data, at least in terms of lab values, is pretty impressive in terms of really favoring TAF. How this translates into hard clinical outcomes is another question. protection. But I think having a suppressed hepatitis B viral load and having normal LFTs is a good thing. So that is the Alliance study. The next study I wanted to highlight was looking at hepatitis B prevention among people with HIV, the Beehive study, which UCSD was a clinical site, so many people are probably familiar with this. And so the rationale for looking at hepatitis B vaccination in people with HIV is probably pretty obvious. We know that people with HIV have lower rates of seroconversion, specifically to a protective level. Depending on which series you read, that really ranges from 20 to 70% compared to populations without HIV, where rates of seroconversion with our traditional hepatitis B vaccinations are quite high, 95 to 100%. So most people are probably familiar with the hepatitis B CpG vaccine. Heplisav-B is the brand name. It's been around for a couple of years now, maybe not that long, maybe a year and a half, 2 years. And this vaccine is a newer vaccine that contains recombinant surface antigen that's connected to a CpG adjuvant, which is an agonist for toll-like receptor 9. It's been studied and approved in adults without HIV using a 2-dose series. And in harder to treat patient populations, such as those with CKD, it's been studied and shown to be effective using a 3-dose regimen. But we really do have limited data, at least in clinical trials, for people with HIV. We've got a lot of experience with this because most of us are actually using this regimen to vaccinate our patients in clinic, even though it's not necessarily approved for people with HIV. But the Beehive study was looking at efficacy of this new hepatitis B vaccine in people with HIV. And so this was a prospective open label interventional study. There were 2 different groups, and I'll only be talking about the results from group B, which were patients who were vaccine naive. Group A is actually the group that I'm more interested in learning about, but that arm is still enrolling, and that's for patients who have been previously vaccinated for hepatitis B, but did not respond to the vaccine. Group B, however, as I mentioned, is just for people with HIV who have never received hepatitis B vaccine. And so in this study, they administered the vaccine at week 0, 4, and 24 weeks. So a little bit different than what we're doing in clinical practice, because currently the vaccine's only approved for week 0 and week 4, a 2-dose regimen. Patients to be included had to be on antiretroviral therapy for at least a couple months or so and demonstrate some clinical response to treatment. Of course, they had to be surface antibody negative and could not have chronic hepatitis B infection, including they could not have surface antigen. And then they also could not be isolated core antibody positive or have received the hepatitis B vaccine previously. And then the primary outcome, which maybe I misspoke and said the study was looking at efficacy, it was looking at rates of seroprotection at week 28, as defined as a titer greater than 10. And so the results were quite impressive, particularly for people who have tried to vaccinate and have patients who do not respond. But of the 74 patients, which was the sample size that they calculated in order to power the study, 100% of people achieve seroprotective antibody levels after the 3 doses. And almost all of them, 98.5%, achieved this seroprotection after 2 doses. And I think what's really interesting is a large proportion, 88%, actually had super high antibody titers greater than 1,000. I will note, I didn't show the baseline characteristics, but the patients in this study did have a pretty high CD4 cell counts, median of like 400 to 500. So that's something to keep in mind, because we know that people with lower CD4 cell counts are more difficult to have that seroconversion. So I think take homes from this study, I'm eagerly awaiting the results for non-responders and really knowing kind of what we should be doing with those patients who have already received the traditional hepatitis B vaccine but haven't had a response. For patients who I'm seeing who have HIV, who are hepatitis B non-immune and vaccine naive, I am starting off with those 2 doses at week 0 and week 4, and then checking a titer 6 months later. That's when it was shown to reach that 98% threshold in the study. And if they're below 10, then I'm going to try and give a third dose. I haven't done this in clinical practice yet because I haven't encountered this scenario. But I think the only caveat will be if insurance will cover it, since this is not currently a 3-dose series, is not how the vaccine is approved or indicated. And then, I think it's just an important reminder that we do need to make sure that we are vaccinating our patients who are at risk for hepatitis B infection, who are not immune, since we're using more and more regimens this day and age that don't contain tenofovir, and so we want to make sure that people are protected. Which is a nice segue to the next abstract that was presented at ID Week. I didn't mention the Beehive study was presented at ID Week 2022, as was this abstract, which was presented by one of our former ID fellows here, and was developed and worked on by our clinical pharmacists at the Owen Clinic, Drs. Yin and Hill, as well as myself. And this was a case series of patients who had switched to long-acting capryl-pivirine, who were core antibody positive and subsequently went on to develop low-level hepatitis B viremia. So the guidelines are very clear when we're switching patients to capryl-pivirine or any regimen that doesn't contain tenofovir. You want to make sure that the patient doesn't have chronic hepatitis B infection and that their surface antigen is negative, because if their surface antigen is positive, you could put them at risk of developing hepatitis B reactivation when you switch their regimen. The thing that we don't really know is, what do we do with patients who don't have chronic hepatitis B infection by a positive surface antigen or by a hepatitis B DNA PCR level, but who are core antibody positive? And so that's what we tried to look at in this study. So this was a retrospective case series of people with HIV who were switching over to long-acting injectable capryl-pivirine. And our inclusion criteria were these people who were core antibody positive, but surface antigen negative. We looked at their pre-switch labs as well as some other clinical characteristics. And then we looked at post-switch labs, specifically hepatitis B labs, as well as whether there was any change to their antiretroviral therapy that was required. So at the time that we did this, there were about 149 patients in our clinic who had switched to long-acting injectable capryl-pivirine. 38 or 25% met our inclusion criteria in terms of being core antibody positive and surface antigen negative. And of those, 3 or 7.9% developed low-level hepatitis B viremia following the switch to capryl-pivirine. And I'm going to go through the details of each of these 3 patients. So this shows the baseline characteristics as well as how things evolved after these 3 patients were switched to capryl-pivirine. So patient A, initially at baseline, had core antibody positivity, of course. Their surface antibody was 6.5, surface antigen negative, and their hepatitis B DNA was undetectable. They had received 2 rounds of the hepatitis B vaccination series, 3 doses each. Their HIV was well controlled. CD4 cell count was 677, viral load undetectable on rilpivirine F-TAF plus dolutegravir. At the time that we looked at this, we were still doing the oral lead-in with cab and rilpivirine. We're not doing that so much anymore. We're just going direct to inject in our clinic for the most part. But at this time, we were doing the oral lead-in for 1 month. And so you can see that the patient A started the oral lead-in. And then when they received their first injection, they had labs drawn at that time, and their hepatitis B DNA level was less than 10, but detectable, whereas before it had been undetectable. And then at their next injection, labs were repeated, and now their hepatitis B DNA level was 95. Surface antigen was still negative, LFTs were still normal, but through shared decision-making with the patient's provider, they decided to switch back to BIC-F-TAF, so having something that was active against hepatitis B, and then more active or fully active against hepatitis B. And then on repeat testing of the hepatitis B viral load, it was now undetectable. So that was patient A. Patient B was isolated core antibody positive, of course, surface antigen negative, hepatitis B viral load was undetectable. We didn't have any vaccination history on this patient. They had not received any hepatitis B vaccines in our clinic. They were suppressed on dolutegravir, bacavir 3-TC. CD4 was a little bit lower, 351, but their viral load was undetectable, HIV viral load. So they got started on the oral lead-in phase. They received their first injection of cabrolpiverine 1 month later. Labs were checked a week or two after this, just due to logistical timing. And at this time, their hepatitis B DNA level was 101. So at this time, FTAF was started until the patient was due for their next injection, but then at that time they were switched back to BIC-F-TAF. And after the patient had been on a TAF-containing regimen, their DNA level went back to undetectable. And again, surface antigen and LFTs stayed normal or negative all throughout this. And then I think patient C is the most interesting and maybe perplexing in terms of how to interpret these cases. So this patient was a patient who probably had hepatitis B before, but had actually developed what we would consider protective surface antibody levels. Their titer was 115. They were core antibody positive, surface antigen negative. This person hadn't had a hepatitis B DNA viral load checked. This patient really struggled with adherence to oral therapy. They had a little bit of resistance. The current regimen prior to switch was boosted darunavir, BIC-F-TAF. Their CD4 cell count was pretty good, 432, but their viral load was 110, and this had been kind of up and down as this person struggled with adherence. And so they were very excited about the injectable therapy. So they did the oral lead-in phase, and then at the time of their first cabrolpiverine injection, had a detectable viral load for hepatitis B, but it was less than 10. And then again, because this patient had really struggled with pills, they decided that they wanted to really continue with injections and then just monitor closely to see what the hepatitis B studies would do. And as you can see at each injection, when this person got labs done, they had very, very low level viremia, less than 10 detected, 14. Surface antigens stayed negative, and LFTs remained normal. So that's the case series. I think it's interesting, but I really have no idea what it means. Is the slow level of viremia completely meaningless and we can just ignore it? Or would certain patients or subgroups potentially go on to really reactivate their hepatitis B in a meaningful way? So we don't have the answers to that, but I think that should be looked at and is potentially of interest. So take homes from this is just, again, a reminder for good clinical practice to make sure that you check all of your patients for chronic hepatitis B infection, especially when you are thinking about switching them off of a tenofovir containing regimen, such as long-acting cabrolpiverine. Also, if they're not immune and eligible for vaccination, you should vaccinate them. And then, we've requested to the ether. I don't know that this has really gone anywhere, but that the initial studies looking at switching patients to cabrolpiverine, Atlas Flare and Atlas 2M, go back, and if they have stored samples, look to see if any of those patients were core antibody positive, and if at any point they developed low level viremia, and kind of how that played out, just to get some bigger numbers. Until there's sort of more of an answer, this is a very soft recommendation that you could consider, again, because I don't know exactly how to interpret this case series of 3, but you could consider following hepatitis B viral loads and LFTs for those patients who you're switching to cabrolpiverine who are core antibody positive, before the switch and then a month or two after. But this is really not backed by anything in particular, just those 3 patients in our experience here. So I will round out our discussion of HIV and viral hepatitis with one abstract that was presented at EASL in 2022, focusing on hepatitis delta. So whenever anyone presents on hepatitis delta, my eyes usually glaze over and I just kind of go to sleep, because while it is interesting and important, I think until recently, the idea of, if I identify a patient with hepatitis delta, giving them interferon for a year really isn't particularly feasible, especially for a lot of the patients that I see. The reason why I present hepatitis delta updates here is because we actually have a lot of therapies that are just on the brink of approval, hopefully that we'll be able to actually use for hepatitis delta moving forward. And so it's just a way of kind of bringing this back to our attention now that we might have some viable treatment options that are a little bit more palatable than interferon. So hepatitis delta, of course, as you all know, requires hepatitis B co-infection. It's fairly prevalent, and we know that it definitely accelerates liver disease, morbidity, and mortality. We do a really bad job of screening for hepatitis delta among our patients with hepatitis B. I've put in the box on the right the AASLD guidelines for which patients with hepatitis B should be screened for delta, but the European guidelines actually say that everybody with hepatitis B should be screened for hepatitis delta. So regardless, if you look at, of patients meeting indications for screening in the US for delta, how many actually get screened? It's like 2 to 15%. So we don't do a great job of screening, and we have some new drugs that are coming along in development that might be available soon. So it's a plug that we need to start doing a better job of identifying these patients, because we might have viable options for treatment to offer them in the future. So this is just one of many drugs that's in development. This is the one that's, I think, the furthest along that I wanted to present. So bulevirtide is a first-in-class entry inhibitor against hepatitis delta. And this was an open-label randomized phase 3 study of patients with, of course, hepatitis B and delta co-infection. They allowed patients with HIV into the study, but the numbers were just very small. And then there were 3 different groups. 2 of the groups received different doses of bulevirtide, 2 milligrams sub-Q daily, 10 milligrams sub-Q daily, and then there was a delayed start group, and so that was the control. And their primary endpoint was a composite at week 48 of hepatitis delta RNA suppression and then ALT normalization. They also looked at a number of secondary endpoints as well. And so this shows the week 24 and week 48 composite endpoint in terms of response to therapy. And you can see at week 48 on the right-hand side, there wasn't too much of a difference between the 2 milligram dose and the 10 milligram dose, but a much better response rate compared to patients who were in the control arm. I'll point out, people that responded, it was only 45% or 48% in the 2 groups. So not a slam dunk in terms of this is going to work for all patients. And it is a daily sub-Q injection that the patients received throughout the study. But, better than nothing, definitely better than the control. The other outcomes that they looked at included fibrosis scores, which improved. And even though this was a sub-Q injection, it was well tolerated. There were injection site reactions, but these tended to be pretty mild. And then very, very few cases of bone marrow suppression that necessitated stopping the therapy. But that was very rare. So this was, I think, kind of exciting. And unfortunately, this drug, I think, just went to the FDA last month and kind of got killed in committee. And the FDA wasn't going to move forward until there's additional data. So it's kind of unclear what's going to happen with this medication and some of the others that are coming. It is currently approved in Europe for very narrow indications. So take homes from this, again, just a reminder that for all of our patients with HIV who have chronic hepatitis B infection, we really need to make sure that we're screening all of those patients for hepatitis delta. And that would be a great QI project for any resident or trainee who wanted to do that for our own clinic patients. And then just to stay tuned for new therapies that I think will be coming down the way, hopefully pretty soon, that we can offer to our patients. So before moving on to the next topic, maybe I'll just pause to see if anyone has any comments or questions. Okay, well, we can also save those for the end. The next segment is going to focus on my favorite abstracts related to long-acting injectable CAB rilpivirine. So the first study I wanted to highlight is the carousel study. And I really like this study because it was an implementation study looking at rolling out long-acting injectable cabrolpivirine given every 2 months across 5 different centers in Europe. And there were 18 clinics that were enrolled in this study, and they basically randomized the clinics to one of 2 implementation arms. So the enhanced implementation group kind of received the Cadillac of rollout. So they had face-to-face teaching in terms of how to give the injections. They had monthly continuous quality improvement meetings where they were able to troubleshoot things, ask experts how to any questions that came up or how best to approach various scenarios that were coming up in the clinic. And then they also received printed educational resources. The standard implementation arm also received the educational resources that were printed, and then just virtual training on how to administer the injections. And then they looked at rates of virologic suppression between these 2 modalities of implementation. I'll say that all of the clinics that were enrolled in the study, none of them had, started giving cabrolpivirine until the study. So it was a relatively novel treatment strategy and approach at each of the clinics. And so these were the results, and you can see combined or overall in blue, and then in the enhanced implementation arm is a solid green, and then the checkered green is the sort of standard implementation arm. And the rates of virologic suppression, as you can very well see, were not different between the groups, and were quite high, actually a little bit lower than what you might expect with cabrolpivirine. This study took place during sort of the height of COVID and a lot of lockdowns, and so they just had a lot of missing data. And I think once they get that data, or if they were able to have that data, these numbers would actually be higher. But main point is that there wasn't a difference between the groups. Also, I didn't present the baseline characteristics, but there wasn't a difference in baseline characteristics between these groups in terms of gender, race, ethnicity, and no difference in terms of adverse events. And these were low in both groups, and also no difference in adherence between the 2 groups in terms of receiving that injection on time within that 7-day window. So I think take homes from this, I was really excited about this study because we have had a lot of success at Owen Clinic in terms of really being able to roll out a lot of our patients getting on to long-acting cabrolpivirine. And that's really important in part due to how well resourced we are in terms of our clinical pharmacists, our pharmacy techs, and our clinic structure in general. When I talk to other people at different sites who don't have as much infrastructure, they haven't really started using this, or there's only a few patients here and there that have started on this. So I think there's both real as well as perceived barriers to rolling this out. And I think this is a really great option for many patients. And so it's nice to see that really just like kind of the basic support implementation of just doing, virtual teaching of how to do the injections and then providing these educational resources really resulted in equivalent outcomes. I think the one caveat to keep in mind is that it didn't look at barriers like insurance coverage or staffing or kind of tracking patients to see, who maybe missed their injection is going to need an oral bridge or that type of thing. So that's something to consider as well. All right, the next cabrolpivirine study, or pairs of studies I wanted to present, were pooled analyses of the 3 studies that I've mentioned already, Atlas, Flare, and Atlas 2M. One study was presented at ID Week 2022, and one was presented at Glasgow. The first looks at neuropsychiatric effects of this regimen, and then the second study looks at efficacy and safety by race and ethnicity. And so just by way of reminder, these initial studies were patients who were started on oral therapy, virologically suppressed, and then were randomized to either switch over to long-acting cabrolpivirine, given either monthly in Atlas and Flare, or every 2 months in Atlas 2M, or to continue their oral therapy. And so the first abstract that was presented at Glasgow looked at neuropsychiatric side effects with this regimen. And overall, neuropsychiatric side effects were pretty rare, although higher in patients who were switched, and this is the pooled data of all 3 studies, who switched to cabrolpivri, 9% overall, compared to patients who were continued on their daily oral therapy. They broke it down by nervous system disorders, psychiatric disorders, and then other, which was mostly seizures. And really, these rates were pretty low, maybe a little bit more headache and dizziness in the cabrolpivri group. I really like this figure because this demonstrates sort of how these side effects played out over time. You can see that the grade of the side effects, or adverse events rather, were pretty mild, mostly grade 1, grade 2, but really they kind of dissipated after a couple of weeks of having been on the regimen. So this is something I think that we can counsel and talk to our patients about, that, you know, if they start to get some headaches or some insomnia when they start their cabrolpivri, that, you know, more than likely this is going to go away after a couple of weeks and their body is kind of adjusting to the regimen. So that was the first abstract I wanted to discuss. And then the other abstract I wanted to discuss, again, that was a pooled analysis of Atlas FLAIR and Atlas 2M, was this efficacy outcome study stratifying by race, ethnicity. And I think you always have to be cautious when you're looking at outcomes and predictors by race, ethnicity, as race obviously is a social construct. But I think a lot of times, well, I don't think it's well documented that many times minoritized patient populations are excluded from a lot of our clinical trials. And so it's nice to see data on patients from these other groups to make sure that we're seeing the same responses, and if not, kind of investigating why. So this just shows sort of the baseline characteristics in terms of breakdown by race, sex, assigned at birth, Hispanic, Latinx, and other characteristics. You can see the majority of these patients in these pooled analyses of 937 patients, most were white, 16% Black, 4% Asian, and then 4% other races. And when you look at and what their primary outcome was virologic response at week 96 in the intention to treat analysis, there was really no statistical difference among these different groups, even though these numbers are a little bit small. And so this shows the virologic outcomes. When you look at adherence to on-time injection sites, these outcomes didn't differ by race and were quite high, 98%. Similarly, there was no differences in these groups in terms of adverse events or injection site reactions. And similarly, the virologic failure was extremely low and didn't differ by race. So I think take homes from these studies: neuropsych symptoms with long-acting cabrolpivri is pretty rare, but you might see it: headache, dizziness, insomnia, abnormal dreams. When they occur, we can reassure our patients that they're probably going to be mild and most likely will decrease after the first couple of weeks. And then nice to see that the efficacy and safety of long-acting cabrolpivri, at least in these studies, didn't differ by race, ethnicity. Okay, and then the last cabrolpivri abstract I wanted to present was one presented by Dr. Orkin, which was updated data from at Glasgow, looking at risk factors for virologic failure with cabrolpivri. So this is actually previously presented data, post hoc analysis, looking at what are the factors that increase virologic failure with this regimen. And the 4 factors that really shake out are shown in the gray box on the right, and those that included having baseline rilpivirine resistance mutations, having a low week 8 rilpivirine trough, having infection with HIV subtype A6A1, or having an elevated BMI greater than 30. And you can really see a difference in these odds ratios, and the elevated BMI is less of an issue than having baseline rilpivirine resistance mutations. And if you had 2 or more of these risk factors, your risk for virologic failure was significantly increased. So this has previously been reported, and this was just expanded multivariable data using modeling, which showed basically the same findings. So in this model, they took out week 8 rilpivirine troughs, just because rilpivirine troughs is not something we are really able to order and use in clinical practice. practice. So it's not something that's accessible in the real world that we would use to sort of say, don't necessarily want to use cabrylpivirine in this patient because they seem to be at increased risk for virologic failure. So again, the outcomes and the findings that we're seeing is that having a baseline rilpivirine resistance mutation really increased your risk, subtype A6, A1, and then having an elevated BMI above 30. So this is, again, nothing new, but just expanded additional data, sort of reconfirming what we already know. So take homes from this, again, I won't belabor this in terms of what the risk factors are for virologic failure. I think the real question that I'm facing in clinical practice is, what do I do with patients where they do have an elevated BMI? So my practice, at least right now, is that elevated BMI, particularly between 30 and 35, is not an absolute contraindication. I think once somebody's BMI is over 35, the injectable that I'm more likely to start as a GLP-1 receptor agonist, and then maybe see some weight loss and then switch over to long-acting injectable cabrylpivirine. But if they do have an elevated BMI and they really want to be on this regimen, really kind of trying to individualize it to the patient, use shared decision making. And if their BMI is greater than 30, they really should be using the longer 2-inch needle to inject and using good injection technique to make sure you're doing everything you can to really optimize the trough levels. And then I think there's some interesting studies pending and some that have already come out, but I am not smart enough to interpret, that suggest that maybe some different techniques in terms of injection site and techniques might be able to optimize and overcome this BMI issue. So that wraps up that segment on long-acting cabrylpivirine. Any questions or comments there? Okay, I will keep moving on, and I'm just going to cover one study looking at antiretroviral therapy in patients with a low CD4 and high viral load. So this was updated data from week 240 of studies 1489 and 1490. And just by way of reminder, these were phase 3 randomized controlled trials of patients with HIV who were newly diagnosed and treatment naive, and they were randomized to either start bictegravir FTC TAF or a dolutegravir containing regimen. And then at week 144, everybody was on bictegravir FTC TAF. And so they looked at the week 240 data for this current analysis, looking at virologic outcomes based on what your baseline characteristics were. If you had a low CD4 cell count or high CD4 cell count, if you had a low HIV viral load or a high HIV viral load. And so I don't think surprising to anybody who uses this regimen, rates of virologic suppression were equal among all of these different stratifications, and quite good. So even patients who had an initial high viral load, the vast majority of them were suppressed. If you had a low CD4 cell count, virologic outcomes were excellent. And if you had a low CD4 and high viral load, which is shown in green, also really great outcomes. So just reassuring that this regimen works even for these patients who are typically excluded or not always actively included in our clinical trials. Other good outcomes from the study: no treatment emergent resistance, adverse events were very low and often mild. There was more weight gain in patients who had a low CD4 cell count initially or who had a high HIV viral load at baseline. I don't think this is surprising to anybody. This has been well documented in other studies, and really suggests that at least some of that weight gain within that first year really represents a return to health phenomenon. But we know, of course, that there's additional weight gain that's associated particularly with our second generation INSTIs as well as TAF compared to TDF. And then there was a median, the median actual weights at week 240 were actually similar among the different groups, regardless of what your baseline CD4 or HIV viral load were. So reassuring that maybe some of that initial weight gain really helps to level or starts to plateau and level off after that first year. And so this was I think an important update that was presented ID Week 2022. So take home from this, BIC-F-TAF is effective, again, for these atypical patients that are not always the ideal patient in clinical trials. And then finally, I will end with a quick update on just one investigational agent, lenacapavir. So lenacapavir is a capsid inhibitor, new in class. It's been looked at in treatment-naive patients with HIV in the Calibrate study, as well as heavily treated patients or treatment experienced patients in the Capella study. Did I say Calibrate? Calibrate is treatment naive. Capella is treatment experienced. And so this updated data to week 52 was presented at ID Week. So just by way of reminder, patients in this study were patients, again, with extensive treatment experience who were failing their current regimen. So they had to have a viral load greater than 400 and resistance to at least 2 agents from 3 of the 4 main antiretroviral classes. And the participants were in one of 2 cohorts, so either the randomized cohort or the non-randomized cohort. The patients who were in the non-randomized cohorts were patients who had entered the study. The investigators repeated an HIV viral load, and they were already seeing improvement as defined by half a log decline or having a viral load less than 400. And so it's thought that maybe these patients were improving their adherence once they got into the study. And so they put them in this non-randomized arm so that it didn't skew the results of the randomized group. So within the randomized group, the participants were randomized to either continue their current failing regimen and start a 2-week oral lenacapavir lead-in versus placebo. And then they were switched to an optimized background regimen and then lenacapavir given subcutaneously every 6 months. And that was another feature that I failed to mention in terms of special characteristics of lenacapavir is that it can be given every 6 months subcutaneously, and so is really nice in terms of being even a longer acting injectable compared to what we have currently approved. So here are the pooled data from both the randomized as well as the non-randomized groups in terms of virologic suppression at week 52 by FDA snapshot. And so you can see that an impressive number, 78% of all of the patients had virologic suppression less than 50, and 82% had a viral load less than 200. There were some virologic failures, which I will come back to in a second on the next slide. And then in the figure on the right, they stratified virologic outcomes based on how many fully active agents they had in the optimized background regimen. And it's really amazing. Even the patients that had zero, I mean, these numbers are small, but even the patients that had 0 fully active agents in the optimized background regimen still had rates of viral suppression of 75%. So kind of cool. And everyone saw an increase in CD4 cell counts with a median increase to by 97 cells. So here are the data in terms of failure and emergent resistance. So 22 patients, again, from both cohorts, the randomized and the non-randomized group, met criteria for undergoing resistance testing. And of these, 9 patients developed emergent lenacapavir resistance, with the most common mutation being the M66I. 4 of these patients, interestingly, they were all continued on the regimen of the lenacapavir and optimized background regimen, and 4 of these 9 patients, even with the resistance, went on to resuppress. 2 of the patients continued exactly what they were on, and 2 of the other patients who went on to resuppress had a slight change in their optimized background regimen. So again, kind of interesting, but important to know that resistance can occur. And I don't think this is surprising given the underlying resistance that these patients already had, and many of them being on functionally or what appears to be essentially a monotherapy. So take home from this, I think impressive for this patient population that can be very challenging to treat with extensive resistance, that lenacapavir plus this optimized background regimen had fairly high rates of virologic suppression. So once this is approved, it'll be really a nice option for patients that maybe don't have any other options. So with that, I will just thank you for your attention. And I will try and unshare my screen and see if anyone has any questions or comments.
I'll just say great job, and I'm also looking forward to lenacapavir. I have a patient or 2 that I think could benefit from it. Do you think we'll keep partially active or failed drugs in some of them, or would you advocate, like, if they have INSTI sensitivity and nothing else, just do INSTI lenacapavir?
I think it depends on what drugs might have partial activity, and I am all for keeping FTC or 3TC on board. Even if there is resistance, I think that has some efficacy. And then looking at like how keeping partially or maybe even fully inactive meds on board impacts pill burden and then ability to adhere. So I think you kind of balance all of those things, and then I get anxious about kind of, tailoring too quickly, but right, it's that catch-22 of the patients that, have a hard time adhering. You want to give them more medication, but right, that doesn't, that's in contradiction. So I think a little devil's in the details there. But I will say, with a high barrier agent like 2nd generation INSTI or boosted PI, that feels better with lenacapavir, if you're narrowing down.
And have you heard any, do we think it's going to be only as the subcutaneous injection, or will it be oral and subQ, or oral lead in, go to subQ?
It's a great question. I think that probably the place where it will have the largest role is subQ, but there might be a place for oral as well. And I think that, and I could be wrong on this, but going directly to injection as well, hopefully will be an option.
Similar to Cabo.
Mm-hmm.
Well, thank you.
Steven!
Hi.
Did you know that was Steven? Darcy? Yeah.
Yeah, of course.
So
we were chatting before.
Okay, sorry. I'm pretty sure, and I don't see anyone from Gilead on, but the lenacapavir oral option has been really nice. We had a lot of patients in the Purpose 2 study who had to go to the bridge oral when the hold was placed. And a lot of patients were saying how much they liked it. It's once week dosing. I don't get the sense that they're doing anything with it. I don't know if that will potentially change. And similarly for HIV treatment. So, but yeah, maybe that'll evolve. It was just very interesting that experience during the hold was so positive for the oral lenacapavir. Darcy, I have a question for you. This is my N of 1 Heplisov series. Someone who had a long history of not responding. We did the Heplisov series. We were 3 months apart because I was just trying to keep him with his regular visits. And this is someone without HIV. Did not respond. And when I looked at the guidance, and of which there's not a lot, and I have to look to see where I saw it, they said to actually repeat the series, not just one dose. So I don't know if that was just based on what they had recommended. And we did revaccinate him, and I did it with the appropriate duration, time spread. And he was then a super responder. Obviously one person. But I'm just curious about the why one dose, why not try to do this series?
Yeah, so I think it's a little bit of semantics. So the regimen that they're looking at for people with HIV is 3 doses. We're doing 2 doses, but that's not the regimen that is being studied in the Beehive study. And so what I was saying was that in the Beehive study, 98, because I checked labs pretty frequently, 98% of people seroconverted after 2 doses. So what I was trying to say was, if you do the 2-dose regimen, right, 0-4 weeks, you check their titer and they've seroconverted, right, 98% of people should seroconvert, then I would say you're done. Especially because I don't know if insurance is going to cover that 3rd dose. But if they haven't seroconverted, then they could be in that 2% that only will seroconvert after 3 doses. So then I'd give that 3rd dose of that regimen. So I didn't really address revaccinating people or re-challenging people who didn't respond to the complete 3-dose series for people with HIV.
That's what that is what I'm trying to remember where I read it, because I was like, oh, now what do I do? And it was definitely in some guidance that suggested doing the series again, as opposed to just 1 dose.
Got
So
yeah.
Anyway,
yeah,
so whatever, that's what you're saying.
No,
I
think that, exactly. The 1 dose that I was saying was more of the fact that for people with HIV, they're recommending or they're studying it as 3 doses. So yeah, I think if the guidance for people without HIV is after 2 doses, they don't seroconvert, then repeat the series, and that makes sense. But I don't know that data, but yeah, I agree with that. Hopefully I'm understanding what you're saying, but if not, you can tell me later too. All right. Well, thanks so much for the invite. Good to see people. Hopefully this was helpful and provided kind of a clinical perspective on things. And yeah, thank you.
Thank you.
Thanks.